Dr. Sunila Jain, who's been the main reason for this program, who has worked behind for this program for more than a month now. She's got more than 23 years of experience in the field of histopathology. She's a senior consultant and Professor Gripmer, Department of Histopathology, Sir Gangaram Hospital, New Delhi. She's also worked as postgraduate and senior residency in UCMC and GTB Hospital, Delhi. She's got 18 years experience of working in Sir Gangaram Hospital as teaching skills, and more than 20 years has been a co-guide and guide for postgraduate thesis. Predominant areas apart from breast oncopathology is also obs and gynae and neuropathology. So I think Dr. Sunila Jain, could you please
yes,
deliver your talk? Thank you.
So today my topic is on the histopathological approach to the breast biopsy. So this is from the biopsy to the diagnosis. So till the biopsy level, we have already finished. Now, how to approach the breast biopsy, which we receive in pathology department. So this will be the agenda. I will not be covering, going through it. So coming to the breast core biopsy now is the standard of care for the initial evaluation of breast lesions wherever it is available. FNAC is a quick, it has its own advantages. It is a quick method, it is cheaper, it has a high diagnostic field, but there are many more advantages of core biopsies. To name a few, it has a high sensitivity and high specificity as compared to FNAC. It has a low inadequacy rate, so it is used at some institutions as a second line of approach, basically when the lesion is inconclusive or there is a discordance in the clinical radiological or cytological findings. CNB is superior to FNAC, especially in the gray zone lesions, which I will be discussing. And it is important to know that CNB is more effectively distinguishing in situ from invasive carcinoma. Another plus point, which is very important in today's treatment era, is the biomarker assessment. So biomarker assessment is done on core needle biopsies. So that is why many institutes, they are doing it as a first line approach. If the lesion is very large, more than 2 centimeters, and the patient has to undergo neoadjuvant therapy, then this is a method of choice. It is also used for tumor grading. So much more data can be given on the core biopsy as compared to FNAC. So coming to the requisition form and handling, it is important to know that the proper interpretation of core biopsies, for that we need the detailed clinical and the mammographic findings. The requisition form should indicate the laterality and location of the targeted lesions. If there are multiple, then they have to specify the main lesion and the smaller lesions. What is the indication of the biopsies, the mass, microcalcification, architectural distortion. So whatever the radiologist's differential diagnosis, it has to mention. Then the most important thing which we correlate is Berard's category. So basically when we are interpreting the biopsy, we have, first we look at the Berard's category. Supposing I am giving a lower grade of benign lesion, and if the category is 4 and 5, I will be in doubt. It has to be repeated. So image guided method which is used, size of the needle used, and the number of pores obtained. If the indication of mammographic micro is for mammographic microcalcifications, then it is important that the radiologist the X-ray for calcium, and these biopsy cores should be submitted separately to the pathology department. So biopsies are immediately fixed in fixative and they sent to the laboratory. Ideally, optimal time, although the other speakers will be discussing on the immunohistochemistry concept, it is very important not to push the histopathologist to give an immediate report, because the optimal time of fixation is minimum 6 hours, which is required for the further biomarker assessment. So from 6 to 72 hours is the optimal time for breast biopsy. Core biopsy is taken for the investigation microcalcification, need further levels. Every lab has its own design. Mostly 1 or 2 levels are sufficient to make confident diagnosis. So coming to the reporting category, these reporting categories are basically recommended by the UK guidelines, and these correspond to the cytology reporting. As we have already discussed, there are 5 categories basically. So when we are discussing B1, B2 categories, these mainly indicate that the lesion is benign. But B1 lesion may include only the normal elements, and it is very important to see whether the lesion has been targeted or not. So it is a multi-team decision to find that out. Benign lesion, when we have specific diagnosis like fibroadenoma, then it is important. So these two out, I will be mainly dwelling on this category, which is the B3, which is of uncertain malignant potential, and then B4 and B5. So core biopsies, when we interpret these biopsies, we have to see that we are doing the assessment, the scoring of these biopsies. So whatever way, we may not write the coding as such like B1, B2, B4, B5, but the interpretation we are giving is based on this. We have to check in our mind whether this tissue is normal, whether it's a benign, is it representing a benign lesion like fibroadenoma, whether we are thinking that these could have an uncertain malignant potential, all of these. The definite diagnosis is possible mainly in these B5. So these findings are purely based on the histopathological findings, whatever presence of findings we are seeing in the tissue submitted. It is not appropriate that if the radiology people have mentioned that this is a B5 score, then we need to put that on. So it should be based only on the histopathology findings. And most of the core biopsy samples which we receive, they are clearly categorized into normal, benign, or malignant, more than 90%. However, small proportion can be. So let's come to the B3 lesions of uncertain malignant potential. So what are these lesions? These lesions are those lesions which may appear benign on core biopsies, but they are known to show heterogeneity and they have an increased risk of associated malignancy. So this finding, whenever a B3 category is reported, is very important to communicate to the surgeons or the clinicians who are treating them that this may harbor a malignancy in the vicinity, or it may progress to malignancy. And traditionally, in the older times, all the high-risk lesions were managed with surgical excision because of the potential of upgrade to malignancy. However, in the most recent guidelines, they have recommended a more conservative approach and sparing open surgery whenever this can be avoided. And for avoiding this surgery, pathologist has to play a very important role in interpretation. So these are the categories of the B3 lesions, and I will be discussing mainly on these three. So papillary lesions is one of the most important concepts which has to be interpreted, and the implication of core biopsy, what do we understand? So this is a papillary lesion spectrum. As we can see, that this varies from benign to papilloma with ADH to encapsulated papilloma and then papillary carcinoma. So categorization of core needle biopsy may be very difficult because papillary lesions have significant intralesional heterogeneity and limited sampling achieved with core biopsy in this area of in situ carcinoma. So how do we diagnose these biopsies? What should be the diagnostic approach? So whenever we are dealing with a papillary lesion, we should ask ourselves, is the lesion papillary? Look for the presence of duct around it. If there is presence of duct around it, then it helps, but many of the samples may not show that because of fragmentation. Is there epithelial ATP associated with it? And are there myopathial cells within or at the interface of the lesion? For this, ISC is important, which include all these following, but out of personal experience, P40 is the most important myopathial cell marker because it's a nuclear stain and it helps better to highlight the myopathial cell. So, most of these lesions are categorized into B3. It is only a very small percentage of lesions which go into B4 when they are strongly suspicious of atypia or carcinoma. So let us see a few of these cases. This is one case which we received of a 17-year-old female with a dilated breast lump, which was big in size. It was Birat's 4A. We can see these spores of papillary lesion. This is a duct around it, and we can see this papillary pattern. There was no atypia. These are the markers we did, and we can see that the markers are present within the lesion as well as at the interface. So with no atypia, papillary lesion, the diagnosis was intraductal papillary. So whenever we see presence of myoepithelial cells within the lesion, There are only two possibilities. It could be a benign papilloma or it could be a papilloma with foci of ADH and low-grade DCI. Moving to the next case, this is a 57-year-old female who had a large solid and cystic mass in the retroeliteral region. This is a biopsy which we received. Clearly, we can see this is a cellular papillary lesion. These are the normal. It is very fragmented biopsy, and we cannot make out the outline from where the duct is, from where the lesion is started, and there is no duct. On high power, we can see that there is apical stratification, there is atypia and increased mitosis. So this was papillary lesion with atypia. We applied ISC markers, and there was absence of myoepithelial cells within the core and only occasional attenuated periphery. ER is strongly and diffusely positive. So what is the diagnosis? It could be papillary DCI, it could be encysted papillary carcinoma since the lesion was circumscribed on the map. So following this, we received the MRM of this patient, and we can see that this is a big papillary lesion which corresponds to the encapsulated papillary carcinoma. There were smaller areas of papilloma and intraductal papillary carcinoma. Along with that, we saw few areas, small foci of invasion. These are the small foci of invasion. So P40 was done, which is absent in both these areas in the invasive component as well as within the course. So this was an encapsulated papillary carcinoma with foci of invasive carcinoma of no specialty. Immunohistochemistry for myoepithelial cells are helpful both in the papillary lesion and in the atypical lesions. The CK5 and 6 and ER, they are very helpful in identifying these atypical papillary lesions on both biopsies. This is a lesion, and if we do a combination of CK5 and 6, it will be absent in the atypical areas, and ER will be strongly and diffusely positive. So combination of these two will help. If we have a circumscribed nodule of papillary carcinoma, we will not see any myoepithelial cells at the periphery. So it will be encapsulated papillary carcinoma. We don't make a diagnosis of PC or SPC or needle biopsies. It is important that even focal epithelial atypia sought as a chance of malignancy in excision specimen is much higher than in lesions without atypia. So we should carefully look for the presence of atypia in a papillary. So these are the practical issues that they continue to be a challenge for the pathologists. There's lack of consensus on the subsequent management strategies. And in difficult core needle biopsies, the potential for the diagnosis should be communicated to the surgeons, and a minority of encapsulated papillary carcinoma may be associated with the invasive. So second lesion is atypical intraductal epithelial proliferation. There's a range of intraductal epithelial atypia which ranges from moderate to it may be just short of DCIS. These lesions are, according to our judgment, we base them into B3 or B4. So we all know that to differentiate ADH and low-grade DCIS, we need the architecture, cytology, and the size criteria of more than 2 millimeter, more than 2 ducts involved. So because of the limited nature of the biopsy, we may not be able to reach the diagnosis of DCIS in some of the cases, low-grade DCIS. So what do we report them as? So we report them as AIDE should be used in the core biopsy. Similarly, as I showed in the papillary lesions, same panel of ISC markers will help in highlighting these areas of atypia. And it is important to know that whenever there is an atypical intraductal epithelium, they have a chance of containing malignancy in the latest pattern. So radial scar, a complex sclerosing lesion. This is a lesion which is stellate kind of appearance with a fibroelastic stroma in the center and with the grab glands at the side periphery which have myoepithelial layer. So most of these lesions, they are categorized in B. Sometimes the lesions can be very twisted and they can mimic a tubular carcinoma, for which we do P63. Then there may be associated lesions which have epithelial proliferation and atypia. So they can have a complex pattern, and there can be foci of invasive carcinoma in addition. So risk of malignancy, however, appears to be low if there is no atypical biopsy. So this is one case. We saw that this is a complex, this is a radial scar kind of appearance. Some of the ducts issued florid ductal epithelial hypoplasia, and we applied these markers. CK56 is positive, P63 negative. ER was not diffusely positive. So this was a radius scar with usual ductal hyperplasia. So suspicious B4 category is usually applied to when we have technical problems, when we are having very crushed or poorly fixed pores. It may be sometimes when we are not able to differentiate low-grade DCIS, some of the papillary lesions, some of the low-grade lesions. But this percentage is very few. Now coming to the malignant, these are the lesions on which the treatment has to be. These are the final word. That is, it is diagnostic. The patient can undergo treatment based on these findings. So this category is appropriate for cases of unequivocal malignancy or biopsy. It may be an in situ malignancy or it may be an invasive malignancy. And the B5 and B5B are the commonest used categories, and most of the books they describe B5C is a very rare category in which we can put sometimes if we're not able to sense whether it's intraductal or invasive. So B5A carcinoma in situ, it is used only when there is unequal DCIS of all grades and in pleomorphic LCIS. That is, if it is classical LCIS, then we don't put it into this category, we put it into B3. And also important to know is that fragments of papillary carcinoma are usually best categorized as B5A. So CNB reporting of DCIS should include all these in the report: nuclear grade, architectural type, presence of necrosis, microcalcifications, if any. At the same time, the clinician should be aware that if the lesion is categorized as B5A, there is a chance that there may be in the vicinity of missing a lesion of invasive carcinoma, which may not have been sampled in that group. So B5B is a category for all invasive breast carcinomas and rare invasive primary breast carcinoma and rare invasive malignancies like malignant phenomes, lymphomas, metastatic tumors. B5, as I have already discussed. So what are the points we do on core biopsies? What all should be reported on core biopsies? So we have to do the prognostic and predictive factors on the core biopsies. All invasive carcinoma should be graded and typed on core biopsies wherever we can. Because the concordance of the grade on core biopsies and the sequence sample is very high, but at the same time, clinicians should be made aware that it can differ by one level in the subsequent sections. Assessment of histological type is very important because invasive carcinoma, if they are undergoing breast conservative surgery, they have to undergo MRI. So grade and type are also useful when there is neoadjuvant therapy which has to be given, because after treatment, they may not have any residual tumor in the specimen. So everything is based on this core biopsy. This is a core biopsy showing IDC. These are the markers which are recommended ERP and HER2 assessment to be done for planning of patient management. And we have seen that there is good correlation of these on the surgical specimen. So this is negative for ER and HER2, which is the. So let us see a few of these cases that there are some cases which we need to be cautious of, when interpreting our biopsies. So this was a 60-year-old female in which we received the biopsy. This is a section which is showing the multiple pores can be seen and very cellular tumor in one of the pores. On higher bar, we could see the solid areas of oval to spindle cells, not looking epithelial in nature. We did markers Y-mental was positive, and at the same time, CK was also. So this is a case of metaplastic carcinoma. They have a pattern of this. Focally, they can be positive for any of the microglial cells. So one should be aware of this diagnosis. Another important pitfall is the angiosarcoma, which can be missed and give a false negative diagnosis when it is very well differentiated. On the other hand, if there is epithelial angiosarcoma, then it can be mistaken for a carcinoma also. So we have to be very careful. If the lesion is being suspected of angiosarcoma, then we should do a panel of markers like CD31 for confirmation. So another case is a 34-year-old female whom we had received a breast mass biopsy in 2022 recently only. This is a biopsy. We can see a cellular tumor, and this is a normal duct, and areas which are showing the tumor lying in pools of mucin. So this is a mucinous adenocarcinoma. When we conducted this ER/PR HER2/neu, they were negative. So this was a clear-cut mucinous adenocarcinoma, which can occur in breast. But when we found the history, this was a known case of mucinous adenocarcinoma in the rectum 2 years prior in 2020, when the breast was negative. So it was diagnosed as mucinous adenocarcinoma 2 years prior. And these are the sections from this. We can see the same morphology we are seeing in the breast biopsy. Panel of immunohistochemistry was done, CK20 positive. Rarely we can see CK20 positive in breast carcinoma. CK7, GATA3 were all negative. So confirming it to be a metastasis from mucinous adenocarcinoma. Metastasis to the breast from other malignancies should be kept in mind, although they are not that common. Complete history, clinical history should be sort of where you're looking at a very unusual tumor, and plus it is triple negative. So, and if there is a case which is already known case of prior history of cancer, then we should rule out this by applying panel. So in conclusion, this is an accurate method for diagnosing breast lesion and can identify the lesion in more than 90% of cases. Certain types of lesion, as I have pointed out, they can present diagnostic difficulties. And diagnosis on NCD is based on the tissue sample and may not be representative of all the pathological findings in a given case due to limited material. This should be known to the clinicians. A minority of encapsulated papillary carcinoma on biopsy, as I had shown, may be associated with an invasive component in the resection specimen, but it's not a very common phenomenon. So radiopathological correlation is essential in every case. That we come to the end of my presentation.
Thank you, Dr. Sunila. I think that was a wonderful explanation on core needle biopsy and in toto with your case reports. That was a nice presentation.